Good morning, good afternoon, happy Friday. My name is Sumaira. I am a patient living with seronegative neuromyelitis optica spectrum disorder. I'm also the founder and executive director of the Sumaira Foundation, a global nonprofit organization dedicated to raising awareness of NMOSD, MOGAD, and other rare neuroimmune conditions. We feel very passionate about community development. We fund research, patient education, patient empowerment, and patient advocacy. And in the spirit of global inclusivity, it's my pleasure to be able to host this program today, which is for the Iranian clinician community all over the world. This idea was presented to me by one of our star ambassadors, Dr. Sara Samadzadeh, who many of you know. And as soon as she brought the idea to us, we said, of course, we'll do this. So this is our second meeting of Iranian Insights. I hope this is of value to all of you. We're so delighted to have a guest speaker here with us today from the University of Verona, Dr. Sara Mariotto, who will be speaking on the treatment strategies of MOGAD. So hopefully this is helpful. Please ask questions, use the chat function, use the Q&A function. But Dr. Mariotto will get to as many questions as she can. And next, I'd like to introduce Dr. Sara Samadzadeh.
Thank you so much. Yeah, thank you so much. And welcome to the Iranian Insight webinar series and also webinar lecture series. And thank you so much for being with us and following us so far. And we try to have so many different vibrant collection of lectures and series together. So we started with the first session like a while ago. That was like more or less case discussion from the Iranian group. And then we had the second one. Second one was a successful collaboration with Professor Aisha Altantash from Koch University. And we had audiences from all over the world, from Montenegro, Colombia, Turkey as well. And this is actually the third one. And we have today this is just a lecture session that and thank you so much thank you, Sara, to Professor Mariotto, to accepting our invite for today. And just before to get to the lecture, I would like to say that we will have today, we will have the July lecture session, then we will have in August one session on diagnostic assay by Professor Patrick Waters. Then in September, we will have the new approved treatment for NMOSD from Professor Mohammad. And then in November, imaging features of MOGAD and NMOSD by Professor Jan Flanagan. So please join us in the further sessions as well. And we will try in between to have also case discussion from the Iranian group as well. So a little bit of introductory. Sara is one of my lovely colleague and friend. We have so far so many collaboration together. She's from University of Verona, the nice and sunny Verona city from Italy. She's responsible for the diagnosis and management of neuroimmunological condition like MOGAD and also autoimmune encephalitis. Her wonderful research focuses in particular in improving the diagnosis of different neuroimmunological disorder, creating proper treatment strategies, and also evaluating biomarker for disease activity. Thank you so much for being here today, and the platform is yours, Sara.
Many thanks for the nice introduction. Of course, it's my great pleasure to be here, and thanks for the nice invitation. I'm really happy to join and be part of this great initiative. So hopefully you can see my screen. The idea today is to discuss with you treatment strategies for MOGAD, so the acute and maintenance therapy. So I will present some slides to show you what has been discussed in literature and what we do in these patients. But then, of course, as Sumaira said, I'm really happy to answer your questions. And so thanks once again, really, for inviting me. So let's start with acute treatment. What we do in patients with MOGAD, either at onset or on relapse, is to treat the acute stage with methylprednisolone, and then in case we have an incomplete response, adding plasma exchange or IVIG. I also include in some slides the dosage we use. Maybe this is useful for doctors or just to take in notes of what we do. So the idea is, as I said, to start with steroids, and then in case add either one of plasma exchange or IVIG. There are no comparative studies showing which of the two is better. So actually, the one for which you have the best management is usually used as an add-on therapy to steroids. But I think the important point to underline is that the majority of cases is responsive to steroids. So MOGAD in the acute stage is a condition which really has a good response to steroids treatment. And for this reason, a relevant point is to add steroids tapering in, let's say, 3 to 6 months after the intravenous steroids treatment. And this is very much important because it's something that reduces the final disability and also the chance of having further relapses. Recently, a paper came out mentioning the optimal dose of prednisolone in adults and in children. That's why I reported here the dosage that this paper proposed. Actually, this is the only paper which mentioned the perfect dosage, but what we do is to do a slow tapering of steroids over 3 to 6 months. Another thing important to mention is that there can be some possible disease reactivation on steroid tapering. So just have in mind that MOGAD is very steroid sensitive. So some cases have relapses during this moment of steroid tapering. And here is how I try to convince you that maybe after this acute stage and the first event, we should not treat MOGAD patients with chronic immunosuppression. We should treat them with chronic immunosuppression only if they have a relapsing course or if they have an incomplete recovery after the first event. Here I show you a paper we published some years ago where we measure in orange NFL values at onset and then over disease course in 2 patients. On the upper left side, a monophasic MOGAD case, you can see the EDSS in blue, and on the right, a relapsing case. And you can see that neurofilament values, which are linked with axonal damage, are increased at onset, but then they decrease over time. They increase a little bit after relapses, but they never reach the values they had at onset. Relapses are marked on the right by arrows. This means and support once again what some other papers related to clinical data underline, that the majority of disability originates from the onset attack, and usually relapsing and monophasic patients share a similar disability. So as you know, MOGAD, in comparison with neuromyelitis optica, has a usually long-term favorable outcome, although we can have some kind of residual disability, especially linked with the spinal cord impairment, but also with visual symptoms. But the general idea is that in comparison with neuromyelitis optica, this disability is less related with the relapses, but much more related with the onset event. This also means that you should treat the onset event properly, which means that you have to recognize it as fast as you can, and you have to treat it with steroids, eventually, as I said, IVIG or plasma exchange, and prolonged steroid tapering. It is very much important to treat and recognize properly the onset event. And this is confirmed also by the fact that insidious disease progression is very uncommon in MOGAD, and usually you do not have accumulation of silent MRI lesion. So, as also mentioned in the criteria, subclinical radiological activity is uncommon in MOGAD and is actually a red flag for diagnosing MOGAD. Here in the MRI part of this table, you can see that T2 resolution is common in MOGAD, more common than in NMOSD and MS, but new asymptomatic lesions, residual T1 hypointensity, or persistent gadolinium enhancement is rare. This means that accumulation of radiological activity, but also clinical activity, as for example, measured by NFL values over time, is really uncommon in MOGAD. And here is just to underline once more this aspect. You can see that in different papers, the idea is that accumulation of silent lesion is uncommon, and that you should not treat patient with chronic immunosuppression after the first event. This is also true because you know that approximately half of patients with MOGAD relapse. Unfortunately, we can't predict those who will relapse, and this is something that we are actually working on. But this also means that probably you should not give immunosuppression to a disease where you have one chance out of two to have relapses in the future, and where accumulation of disability, as I said, is mainly driven by the first event. And in this table, you can see, well, there are different important aspects, but I wanted to underline a couple of them. You can see that long-term attack prevention is, of course, recommended for neuromyelitis optica. You will discuss about it in the future seminars, but not for MOGAD, where it is reserved to those with 2 or more attacks. And unfortunately, you can also see that high levels evidence of treatment efficacy is not available for MOGAD. But there are some clinical trials ongoing, and this is the good news. Another point that I want to mention is the definition of relapses in MOGAD. Well, we know from other conditions that relapses are some clinical events corroborated by radiological lesions, which last more than 24 hours and occur 30 days after the previous relapse. And this, as I said, should be treated as acute event. But in this nice paper, Michael Levy and colleagues proposed the different classification of relapses in MOGAD, mentioning also trigger relapses, which means those relapses which are triggered by oral steroid tapering. As I said before, MOGAD is very steroid sensitive, so that can be that some symptoms worsen during steroid tapering. And the question here is, should we define this as a true relapse or not? The same thing is if you have a relapse within 30 days from the previous event, which actually, according to the definition, should not be defined as a relapse, but as a polyphasic event. And as I mentioned also, it's unusual that you have MRI activity without clinical symptoms in MOGAD. So another question is how to interpret these new MRI lesions in absence of clinical symptoms. So the idea is in MOGAD is to define a real relapse only if you have an event which is 30 days after the first event and potentially not on steroid tapering, because otherwise this means that maybe it's something related to the antecedent event. And here I just want to mention you some tables which I found useful for deciding what to do in MOGAD. And once again, here you can see that the idea is to reserve long-term immunosuppression to patients who relapse and not after the first event. Here is an algorithm that we use, as I mentioned, for the acute treatment, but then also for single attack or relapsing cases. As I said, for single attack, we just use oral steroid tapering over 3 to 6 months. For relapsing cases, or for those who had an incomplete recovery, we start immunosuppressant. The question is which one we should use. So as I said, there are no comparative studies, no clinical trial published yet. So these are the drugs, the one that I reported, for which some evidence has been reported for the use in MOGAD. But then we will discuss them further. Here is an algorithm for the treatment of pediatric patients, which is more or less the same. So we should treat the acute event, then do an oral steroid tapering. And once again, if you have a relapse, treat it, acutely, and then consider maintenance therapy in relapsing cases. Once again, potentially with mofetil mycophenolate, azathioprine, rituximab, or IVIG, and then see what happens, and in case, change immunosuppressant if you have further relapses. The same algorithm has been proposed for adults, where you can see that in relapsing cases, different treatments, the one that we mentioned, are proposed, but unfortunately, that there are no studies comparing them. So actually, we can choose the one that we think could work best, maybe the one where we have the more practice on, but there are no comparative studies on them. Another important point is that now some authors propose to do a kind of de-escalation therapy when you have a patient who is stable for 2 years. So who have no relapses and is stable in 2 years. Actually, some papers are coming out on this. And here I just want to mention the treatment, the potential treatment and the dosage that we use for relapsing or patient with MOGAD with incomplete recovery. I just want to mention that IVIG showed quite good results in both the pediatric and adult population. So I think that are an important treatment with, as you know, really reduced side effects. There are also some patients on subcutaneous IVIG, which is also a potential treatment, maybe more easy to be administered. There are reports, of course, of azathioprine, mycophenolate, rituximab, and tocilizumab. As for rituximab, I just want to mention that the efficacy in MOGAD is less than that on NMOSD, and have also been reporting relapses despite B-cell depletion. Then I want to mention the couple of trials I just mentioned before. There are 2 ongoing trials for patients with MOGAD. The first one is on satralizumab. You know that satralizumab is an we all know that IL-6 is involved in patients with MOGAD. We have high levels of IL-6 in both serum and CSF. And so the idea was that blocking interleukin-6 mediated signals can reduce inflammation and improve blood barrier integrity. So the proposal of these trials is to use satralizumab, which is a monoclonal antibody with high affinity for interleukin-6 receptor, which can inhibit the signals mediated by this cytokine. And here is the design of the study, just to mention that there is a double-blind period. The inclusion is that of adults with relapsing MOGAD, and they should be randomized through a satralizumab or placebo. Actually, immunosuppression is admitted, concomitant immunosuppression, and after the double-blind period, the open-label period of the study starts. The other trial, which is going on, is with rozanolixizumab, which is a humanized IgG4 monoclonal antibody which target Fc neonatal receptor, which has a key role in the distribution, transport, and persistence of IgG. So the point is that this monoclonal antibody help the degradation through the lysosomal pattern of IgG, reducing, of course, the MOG IgG. And the design of the study is similar, although you can't use concomitant immunosuppression in this study. And there is once again a placebo versus a drug randomization and then an open label stage. And just to conclude, because before answering your question, I want to mention how we should monitor disease over time. Because of course, I think that there are 2 unmet needs in MOGAD. The first one is to recognize patients who will relapse, because we really do not know. We have just 50% of cases, 50% of probability that our patient will relapse. So I think it's very important to focus research in trying to select those cases who will have a relapse, which means that they should be treated with chronic immunosuppression from the beginning. And the second point is to find a good biomarker to monitor patient over time. And actually, of course, we can use the clinical evaluation. Another point is to monitor MOG antibody titer over time, which is important. But we know that usually patients who, let's say, who are going in the right direction, so they feel better, the clinical evaluation is better, they do not have any kind of radiological activity. Usually, in these cases, we have also a reduction of MOG antibody titer. But this is not a rule, because we have some cases with increasing MOG antibody titer and a silent disease course, or with reduced MOG antibody titers and relapses. So I think that monitoring MOG titer over time is important, is relevant, and is something that we do. For example, every, let's say, 3 to 6 months over time, we see the patients and we monitor the antibody levels. But maybe this is not enough. So the idea is trying to work, and it's something that we are doing also together with the Sumaira Foundation, to create a novel biomarker which can really help us monitoring disease over time, and also, as I mentioned before, recognizing relapsing cases or those who need really immunosuppression, also because they have an incomplete response to acute treatment over time. And I think that this is the end, and I'm happy to answer your questions.
Thank you so much, Sarah. Great talk. And I would like to ask Professor Sahraian also to join the panel. And maybe could you please, Professor Sahraian, introduce yourself for the non-Iranian community here, and then also talk a little bit or discuss a little bit the situation for MOG antibody and MOG assay in Iran, also the treatment strategy in Iran. Thank you.
Thank you very much. Good morning, good evening, everybody. It's really a pleasure to be here. And before everything, I would very much like to thank Sumaira, Dr. Samadzadeh, and Professor Mariotto for having this conference for the Iranian. It's really a pleasure. And thank you very much. Actually, cell-based MOGAD is not available at the moment in Iran, and we are trying to do this with the help of Sumaira Foundation, and everything is on the wheel, and I think there will be in the next 2 months that we could check it. Now we are collecting blood in our center. For introduction, I'm Mohammad Ali Sahraian, Professor of Neurology, Head of MS Research Center at Tehran University of Medical Sciences, and Vice Chancellor for Iranian MS Society. Can I start with the question? I have 2 or 3 questions from Professor Mariotto. These are the questions that have been raised during our teaching courses on MOGAD. So can I, Sara, can I ask the question?
Yeah, of course, yeah, of course. If I have like, please, to other audiences, will use a Q&A bottom here to just send the questions, and also you can also use chat to send the question directly to me, but please, Professor Sahraian.
Yes. Thank you very much, Professor Mariotto. Again, there are some questions raised in our teaching courses. One of them is that how long you will wait for a relapse to recover, that you say this is an incomplete recovery. For example, if a patient with MOGAD developed an attack and you plan to start immunosuppression because of incomplete recovery, how long will you wait? 3 months, 6 months, or less or more?
Yeah, this is a very relevant question, actually. I think it's important to mention that some symptoms, for example, bowel or bladder symptoms, take a lot of time in MOGAD to recover completely. So what we do usually is, as I said, to cover patients with steroids for 3 to 6 months. And this is the time that we wait for saying that the patient had or not a complete recovery, because we know that actually these symptoms can take time to recover completely. Some patients have a kind of improvement, but not complete. Usually visual symptoms recover quite well and quite fast, fortunately. But yeah, this is not the case for cauda symptoms. So I think that you should wait, let's say, the time of steroids tapering, and in any case, in that period, you are covered by steroids. So I think it's not so bad to wait a little bit, so to give the chance of the acute stage of the disease to be completely solved, because taking this decision on long-term outcome.
The next question is that what is the definition of recovery? For example, if a patient develops more than 50% of what is lost, is recovery, or you think of the full recovery for the patient? For example, on motor power or optic neuritis, if a patient has recovered 80% of before the attack, do you consider it as full recovery, or you are waiting for the 100%?
Yeah, this is another important point. And I think that you properly mentioned the fact that we actually do not have a proper scale for measuring disability in MOGAD, because we use the EDSS as for a neuromyelitis optica. But I think that the EDSS is not the perfect scale, nor for neuromyelitis optica, and even less for MOGAD. So this is also something that we should work on. But in this case, for recovery, I would consider complete recovery, because patients with MOGAD are expected to have a complete recovery. And if not, I think I should go with chronic treatment.
Thank you. There is actually some data, and there are some actual lectures coming from different parts for starting maintenance therapy, comparing rituximab with azathioprine or mycophenolate. And actually, it is said that mycophenolate or azathioprine is more beneficial or more effective comparing to rituximab. And usually it is said that it's better to start for maintenance therapy mycophenolate mofetil or, for example, azathioprine comparing to rituximab. So what is your routine practice? Do you consider also rituximab in this patient, and how you differentiate these patients to start rituximab, azathioprine? Actually, one of the main questions in Iran is, after finding a case of MOGAD, and we want to introduce long-term treatment with immunosuppression, how we can differentiate between starting azathioprine, mycophenolate, or rituximab.
Mm-hmm. So there is an ongoing trials of rituximab, and also, as I said, the other trials with, well, different drugs. So up to now, well, there are not published data yet for saying which is better than the other. But as I said, what we know is that rituximab is less effective than in neuromyelitis optica. So the general idea is not to start with rituximab. Well, I think that, for example, IVIG really works well. We use them in the clinical practice, especially, for example, in cases who have a kind of almost complete recovery, but we are not totally satisfied. So we are not sure, for example, to give the risk of the patient of chronic immunosuppression. So I think that it is an option that should also be considered. And there are some published data which are very, very nice. If we think about azathioprine, mofetil mycophenolate, or also tocilizumab, well, I think that, I like MMF and also tocilizumab in these cases, but there are no data reporting a comparative study between them. So usually what people do is what they think they have a best management on, and what they have more experience on, and what they prefer. But what we do, for example, is, well, now we recruit patients also for the clinical trials. So this is the other option we have, because I think that it's very much important to have some proven data that something works, because otherwise we will never have anything which is approved or we are sure it works in MOGAD. So what we do is think if we can recruit patients for clinical trials, and then consider among the first IVIG, as I mentioned, MMF or tocilizumab. I also want to mention that tocilizumab was also used in one acute refractory case, which is published in literature. So is the other additional option we should consider if we have any problems in the acute stage.
Thank you. I think we have questions in the Q&A. Dr. Samadzadeh, you can go on. Thank you.
Of course, yeah. Just the first one from one of my colleagues from Turkey, Mirol. So thank you for presentation. In adults, after 5 to 7 days mega dose treatment, we usually continue straight 1 milligram per kg at least 1 month, then lower dose. How is your approach?
Yes, it's right. I showed you the escalation strategy proposed in that paper, because it's the only one who tell you really what dosage you should use. But we do the same. So we do intravenous steroids, then we go to 1 milligram per kilo, and then we do a very slow tapering. In that paper, they propose this rule, which is very strict, it's fine. But I think the important thing is to just do a very slow tapering. If you do not have a difficult side effect to be managed, like hypertension, diabetes, or things like that, and you can, I think it's better to do a really slow tapering, because it is the only thing that can help you preventing relapses. So I think that this, which was mentioned by your colleague, was a very good strategy. We also do like this. And then we really very slow up to 3-6 months, maybe more better than 6 than 3. We do a very slow steroid tapering.
And the next question also you answered already, but thank you from one of my colleagues from Iran. Thank you. What is your choice between immunosuppressive for MOGAD, azathioprine or CellCept, or maybe cyclophosphamide in some patients?
Yeah, I think is what we said before. Yes, we do not have any written rules, but yeah, I would go like that. And just to mention that in addition to immunosuppressant, we should also think about IVIG. I don't know how is in Iran the use of IVIG. In Italy, we had some problems related to the restriction of these drugs because we didn't have enough. But I think that if you have, this is something that should be taken in mind.
We have the same issue in Iran. Sometimes we run short of IVIG, and sometimes we cannot give a so high dose of IVIG every month for the patient. So we have the same issue actually.
Yeah, this is a problem because I mean, I think that there are some patients where you have maybe infectious comorbidities, or as you mentioned, you're not sure because they had almost complete recovery. So you're not really sure if you want to give or not immunosuppression. And maybe you want to add them in the acute stage, so they are a very good option. But anyway, there are some issues that, yes, should be taken in mind.
And the next question is from one of my colleagues from Montenegro, Sania. Thank you so much for joining us. And if you have a patient with bilateral optic neuritis resulting in severe visual loss in one eye, who has relapsed on azathioprine and is stable for 2 years on rituximab, do you think is wise to de-escalate rituximab, maybe extend the dosage and stay on it for 5 years and then de-escalate?
Yes, so I think that there are some data on de-escalation, which are actually coming out in these months. So the algorithm proposal that I showed you before is considering stopping treatment or de-escalation after 5 years. So we do not know. There are some papers coming out, but in this moment, since data are coming out, I would be cautious in stopping after 2 years. But maybe after 5 years, I think that could be a good idea. Although, as I said, there are papers coming out, so maybe this will change in the future. But another thing that you should do is to see how is, as I mentioned, the MOG antibody titers, because if it's clinically stable, no disease activity, nothing on neurological evaluation, titer is 0 or decrease, this is something more that can maybe support you in the escalation treatment. There are unfortunately no data, but on these things, things will come out soon.
Thank you so much. I don't have any further questions here.
May I ask Sara the other questions which we raised? Actually, there is another question for the cases of refractory MOGAD. We have cases of refractory MOGAD actually starting, for example, rituximab, and there is a new attack after rituximab, even not in the first month that we consider that this is immediate post-infusion attack, maybe after 3 months. Or the cases who attack on azathioprine, what do you manage? How do you manage? Do you consider combination therapy in these cases, or do you consider to change the treatment strategy, for example, from rituximab to IVIG, or from actually mycophenolate to rituximab, or you do combination therapy?
Yes, so the idea, which is also mentioned in the algorithm that I showed you before, is to switch to another immunosuppressants. And if you have to combine a strategy, the best combination is with whatever you're using and IVIG and in case steroids. So change is the first idea. And then if you want to combine in these free with these free drugs.
Okay. Thank you very much. Thank you.
And another question again from Miral. How long do you use IVIG monthly, and for example, after 6 months, do you give IVIG extend intervals, and do you use MOG antibodies for clinical follow-up at the moment?
Yes, so we usually administer them monthly. as we do, for example, for a CIDP or whatever. And as I said, there is a report led by John Chen on the use of IVIG in adults, where we also participated. And there you can find also some data on the idea of prolonging the intervals and dosage. And as for MOG antibody titer, well, as I said, I think it's important to monitor it, of course, using a cell-based assay, potentially a live cell-based assay, because you have a really prompt evaluation of the levels that you have. And I think that they should be monitored, let's say, every 3 to 6 months over time. Usually we monitor them even in negative cases, really recover completely, you know, just to see and to follow them over time, maybe every 6 months, later on every 1 year. But I think that also thinking on the escalation treatment, the idea of monitoring MOG antibody levels makes sense. As I said, it's not a rule, but it's something that can help you in addition to clinical evaluation, which is always the best and most important thing to do. But I think it's very much important to monitor over time. Also in patients with optic neuritis, OCT over time, it makes sense. But I think that antibody levels are very sensitive to disease evolution. Another thing that I didn't mention, sorry, is that maybe this will be better discussed by Paddy on the diagnostic relevance. But as you know, we also reported some patients with CSF-only MOG antibodies. Of course, you can't monitor CSF levels over time. But what we saw was that the presence of CSF MOG antibodies was not related with a relapsing course, but was related with a more severe outcome. So this is something that we wanted to explore more, to see if CSF antibody presence is linked somehow with the final outcome in these patients.
So thank you so much.
There are two confusing actually situation that we have been asked a lot of times. One of them is for the patients who seems to be MOGAD or NMOSD double negative. For example, a patient who has developed one episode of optic neuritis, the recovery is not full, even the patient has become, for example, blind, but there is only one attack. You don't know being double negativity is due to lack of good laboratory, and you cannot check, for example, cell-based NMO or cell-based MOGAD. How do you consider long-term immunosuppression for this patient? Do you consider at all long-term immunosuppression or not? This is one of the questions. Or for example, a patient develops severe myelitis, double negative, but only just one myelitis, and the recovery is not full. So this is one of the confusing cases that we have been asked several times. And I would very much like that to have your practice in Italy.
Yes, so I think the problem is, as you said, is when you have a highly suggestive case, but you do not have access for several reasons to the assay. So for neuromyelitis optica, we know that if you do not have the results of aquaporin 4 antibodies to diagnose neuromyelitis optica, you need the additional features. For MOGAD, according to the proposed criteria, you can't diagnose MOGAD if you do not have a MOG positive assay. But sometimes you do not have access to the MOG assay. So it doesn't mean that it's negative. It means that you are not able to test it. And this is a big issue because, of course, when you have myelitis or optic neuritis, can be whatever, like inflammatory, infectious, or whatever. And then it's the same with autoimmune encephalitis. I mean, if you do not find the antibodies, then yeah, you don't know what to do. And yeah, it's very difficult when you do not have access to the results. So I think that the only solution to this, I mean, because then you are in trouble with the clinical treatment of patients. I mean, should you give immunosuppression to someone who has a highly suggestive phenotype to be inflammatory, MOGAD or whatever, but the results is not available, of course, this is an issue because they are not supported by literature or anything. So what I think it's we should do, the only thing that we can do is to try to support whoever doesn't have access to the essay doing the essay. And it's something that, of course, I'm happy to do. I mean, I know maybe you have already connection with Paddy or whoever, but if not, we are also happy to support this. So sometimes, for example, we do MOG antibodies assay for research purposes. We do it for Italy, but also for other countries. And I think it's very much important for people who have access to the assay, like in our lab, to help whoever doesn't have access, because it's the only way that you can really have a proper diagnosis and give proper treatment. So, I mean, of course, it's not only my lab, for sure there are also others, but from my side, if you need any kind of support doing the MOG assay, we are happy to support you.
Thank you very much. Thank you. Thank you.
Thank you so much. We don't have any further questions, I think. So, Sumaira, I will pass to you. Do you have any remarks and like a recap the session?
Oh, I mean, it was very, it was very insightful as always, which is perfect for Iranian Insights. And nothing makes me more motivated and inspired, you know, than seeing people from different parts of the world coming together for a common cause. It's very fascinating. I'm sitting in Boston, Sara Mariotto sitting in Verona, Samadzadeh sitting in Berlin, Professor Sahraian, you're in Iran. It's just really nice to be able to connect the dots. So I'm glad, you know, that our diseases are connecting the world and making it a smaller, safer, healthier place. So to our live audience, I hope that this was, you know, that you learned something new, that you were introduced to great people. And if there's anything that we can do to support you, please let us know. But I will just put out a plug. If anyone is going to ECTRIMS, we are having a gala on September 17th at the National Aquarium of Denmark. The location is 10 minutes away from AC Bella Sky. This is how we raise money for research. So if you are able to attend and you're local, we welcome all of you to join us. The information will be available next week. But just a very big thank you to Dr. Mariotto, Dr. Samadzadeh, Professor Sahraian. Thank you so, so much for doing this. And I look forward to our next meeting, which I believe is in August.
Yes, yes, yeah. Thank you so much for your support, and to all of you, thank you for being here and for the support, you know, from the nice and lovely faculty member of UCF for this series. And thank you so much to thank you to Professor Sahraian for also support us from Iranian side. Have a nice day and have a nice weekend.
Thank you. Bye.
Thank you very much. Thank you.
Bye.
Bye-bye.